Okay. Okay, so I am Jean Table from Paris. I am sharing this round table, which is not very round, but okay, with my colleagues and friends. Bernd Saugel, can you introduce you?
Sure. Hello, my name is Bernd Saugel. I'm a professor of anesthesiology at the University Medical Center in Hamburg in Germany.
Bakker.
I'm a professor of medicine in Erasmus University Medical Center in Rotterdam and the Catholic University in Santiago in Chile.
Daniel Bakker.
Brussels. And Xavier, Monnet, Paris.
Okay, thank you very much. So the topic of our session is about measurements of cardiac output or monitoring of cardiac output, and what is the best time to measure cardiac output in a patient in the ICU. So maybe I will go to my laptop just to have some ideas. I would like to take an example of a patient who is arriving at the emergency department. He's not in a good shape. He has shock, mental confusion, mottling, fever, 39 degrees. Blood pressure is 70/35. So systolic is the double of the diastolic. Heart rate is 100. Has some dyspnea. He was not very well the day before coming to the hospital with some increasing dyspnea, cough. And so I repeat, heart rate is 100. Blood pressure is 70/35 with mottling. My question is first to the audience. Do you monitor cardiac output? And how? Who monitors cardiac output? You can, yeah? You too? 4, 5? Who not? 1, 2, 3. You. With your left hand, you say, I monitor. With my right hand, I don't monitor.
I don't know if to call it monitor, but doing a point of care echo to get an assessment would be my choice.
Others who do not measure at all in this patient. I repeat, just arriving, no catheter in place, nothing. Heart rate 100, blood pressure 70/35. Mental confusion, mottling, shock. Yes, you don't?
I think not at this time, because I know I have some therapies in mind before I will measure cardiac output.
Okay. So, the same question to the experts. Bernd?
At that time in the emergency department, I would not monitor cardiac output. I would start continuously measuring blood pressure with an arterial catheter, and I would also perform an echo.
If you have an echo machine?
If I have an echo machine, otherwise?
Otherwise.
I would only measure blood pressure at that stage.
Jan?
Well, the problem is a circulatory problem. You have low diastolic blood pressure, you have mottling, and you have, let's say, abnormal conscious level, so you have an inadequate circulation. I don't care what the cardiac output is, so I would start with a fluid resuscitation and see if anything changes. If after a fluid resuscitation, nothing changes, yeah, then you get into trouble, and then I will get my echo machine. And if it's 35 and nothing happens in the 10 minutes of the fluid infusion, I would start norepinephrine, whatever the cardiac output, but get an echo machine to look at the heart.
So you would start norepinephrine 10 minutes after beginning fluid resuscitation, if nothing happens, if nothing better happens.
Yeah.
And you give norepinephrine without measurement of cardiac output?
Yeah.
Okay. Daniel?
After fluids,
After
not
fluids.
before.
Well, the question is a little bit artifactual, but artificial, sorry. But I mean, it's. I mean, in your priorities, I mean, indeed, you need first to initiate your therapy here because your patient is really in trouble. I guess that the fluids plus minus vasopressors will be needed given the low diastolic pressure, but okay, I mean, I still do not have an adequate diagnosis. I know that there is some inflammatory process because of the vasodilation. It seems not to be cardiac shock, but at some point, I would be reassured to have some clues of the cardiac function, pericardium, and so on. And so I think that the point of care echo is relatively rapidly performed, and in my department, I don't have to bring the echo device to the department because it is in the department. And so you just have to switch on, which is 10 seconds. And so it's probably as rapid to put the probe on the chest of the patient than to prepare the norepinephrine. So I guess that it will be done more or less at the same time.
Yeah, I agree, because what would be, I think that at this very early time, knowing cardiac output is not very useful. For sure, it may help me for shock diagnosis, because I expect that typically in septic shock, cardiac output would be high. Nevertheless, there are other arguments for septic shock. I do not need cardiac output for this diagnosis. And cardiac output will increase in any case at this very early phase with fluid infusion. So I think it's not really mandatory at this time. The question is just to give fluid immediately and perhaps norepinephrine early in some cases we may perhaps discuss. So again, decisions that are not based on cardiac output at this phase in any way, this is not feasible so early. However, with the echo assessment, which is absolutely mandatory, I would like to know velocity time integral just to be sure that it's not too low at this very early phase, and of course that the cardiac function, contractility, is not decreased.
Can you have some cardiac dysfunction early in septic shock or not? This is a question I asked to the panel. Is it possible to have cardiomyopathy, septic cardiomyopathy immediately when the patient is arriving, or is it late as it was written in the textbooks in the 70s?
I mean, the data from Antoine Verbaron mentions that it is relatively early. Early is still assessed at the ICU admission, which is a little bit, of course, later than the stage at which you present the patient, but it's 1/3 of the patient may have already some significant cardiac dysfunction already on admission. And so also you did not mention what was the previous medical history of this patient, has he cardiac dysfunction or not. And so I think that already knowing the cardiac function will help me to guide the further fluid administration, because we know that it's not a story that will be ended by just one bolus of fluid. So we know that it's just a first step in a long step issue, and so it's good to know already have the first image of where we put our feet.
So this patient is around 70 with no cardiac dysfunction, but history of chronic hypertension. Okay. I have a question, because I told you that the blood pressure was 70/35. So what do you think about stroke volume? Can we have some information about stroke volume in this patient or not? Just by looking at the pulse pressure, which is the difference between the systolic and the diastolic.
Indeed, just looking at blood pressure, we know two things. The first, that stroke volume is rather high because it's reflected by pulse pressure, systolic minus diastolic, which is quite large.
No, it is 70/35, so 35 only. 35.
So the pulse pressure.
70 minus 35.
Yes, so it's
35.
35, yes, indeed. So
It's
it's not high.
It's not large. Yes, for a patient with supposed arterial stiffness, 35 is not very high.
Yeah, indeed. So you're right, it's not high. And I know that the patient is strongly vasodilated because of the diastolic blood pressure. Then stroke volume is likely low. Perhaps there is previous cardiac dysfunction or existing cardiac dysfunction. Perhaps also the patient is deeply hypovolemic, which may also explain a very low cardiac output at this phase.
So probably at a glance, I agree, of course, Xavier, at a glance, if you have a patient with history of chronic hypertension and a pulse pressure of 35, probably it means that stroke volume is not high, because stroke volume, pulse pressure depends on stroke volume and arterial stiffness. So we can imagine that this patient has stiff arteries, so normally he should have a higher pulse pressure for normal stroke volume. If pulse pressure is low in this case, probably stroke volume is too low. So at a glance, we can have an idea about stroke volume and cardiac output, and also vascular tone at a glance. So we don't need to measure cardiac output just immediately. We need to perform echo just to know if this low cardiac output is due to hypovolemia, which is likely in this case, or cardiac dysfunction, because we don't know about the history, or we don't know about the occurrence of some septic cardiomyopathy accompanying septic shock. Okay? Okay, so you give fluid plus probably norepinephrine rapidly because of vascular tone, which is low, and the patient improves, but you transfer the patient to the ICU, everyone? Yeah? Because of shock. Do you intubate this patient with a respiratory rate of 40, dyspneic patient, mental confusion?
I think that depends a little bit on the response to the initial treatment. I mean, if nothing happens and he keeps, let's say, wasting a lot of energy on breathing, and I have corrected my diastolic blood pressure so that I can safely intubate. I would never intubate someone with a diastolic of 35. That's asking for a lot of trouble. Then I would reduce the oxygen demand, which is a very simple way to preserve cardiac output, whatever it is, because you free up about 25–30% of your cardiac output to use for other organs. So yeah, I would definitely try, if the conditions are safe, to intubate the patient.
Okay. Do you have questions at this step? Okay, we intubate the patient. We transfer the patient to the ICU. We perform echocardiography. After fluid resuscitation, or more or less during fluid resuscitation, we gave norepinephrine. Echocardiography was relatively normal, I would say. VTI a little bit low, which is consistent with the low stroke volume we imagined before, but there is no cardiac dysfunction. Diastolic blood pressure still low, so you continue to give fluid, you continue to increase norepinephrine. My question is, do you think that measurements of, because the patient has a central venous catheter in place, an arterial catheter in place now, do you think that measurements of additional variables like PCU2 gap, like SCVU2 are useful?
Well, to be honest, I think mandatory.
Mandatory,
I mean,
because it is not in the surviving sepsis campaign guidelines.
Yeah, but I don't care about the surviving sepsis guidelines. So, I mean, the question is, do you have adequacy of flow? And the only way to answer the question is to have indicators of inadequacy. Now, that doesn't mean that if your indicators are normal, that you have adequate cardiac output. That's, of course, the caveat. Then you come to cardiac output monitoring and doing interventions and stuff like that. But at the early phase of this, I'm interested is whatever the cardiac output is, do I have an index that this is adequate, acceptable, and then SCVO2 and delta PCO2 are the only things, except for, let's say, the peripheral circulation, if that's still abnormal.
This is your attitude to measure SCVO2, to measure PC2 gap?
Who dares to say no?
Yeah.
A lot of patients at this age have, if they smoke, they have some degree of obstructive disease. How does that affect your PCO2 gap, and how do you manage?
Should not have a huge effect on your delta PCO2, but it depends on your cardiac output. So if you're already in a high cardiac output, it's probably not that relevant anymore. But in and of itself, it should not have a huge effect. And then you should always combine it with SCVO2. So you have, I mean, that's the two markers that you have, and then your peripheral.
Xavier, you want to?
Yeah, but the PCO2 gap is the difference between the veins and the arteries. That's why it's not influenced by baseline PaCO2. That's the big advantage of the PCO2 gap. So it does not depend on ventilation. That's the advantage. You don't look only at the venous PCO2, but that's the difference. I would say, yes, like, of course, it's useful, as you said, but at this very early stage, who can imagine that lactate is normal and the PCO2 gap is normal, and etc. So, yeah, for sure, I will need some indices of adequacy of cardiac output with oxygen demand, but perhaps not that useful immediately.
But you're already after a fluid resuscitation. You already started norepinephrine that increases cardiac output as well.
If we're still very early, I mean, just I don't know, half a liter of fluid, or of course it will be elevated.
Thank you. Well, just last week I had about SVO2. I had one guy, 21 years old, admitted after peritonitis, a reintervention, and he had norepinephrine 0.2, and without monitoring cardiac output. After monitoring cardiac output, 2.1, 65 of SVO2. And so I think that that patient needs dobutamine instead of norepinephrine. So that's so we think that in septic shock patients the problem is only to give norepinephrine and not inotrope, but sometimes even in young patients they need inotrope therapy.
But you without echocardiography or with?
Echocardiography was not particularly impaired, and volume status was okay, and but 2.1.
So you mean if I summarize, a young patient,
21 years old with anamnesis negative.
Receive fluid norepinephrine,
yes,
with SCVO2 still
65%. 65%, yes. And of course, with a normal
without
SP
argument,
and with a normal arterial saturation, of course.
Who wants to comment? Daniel?
I mean, I think that it's very difficult to comment on one specific case. We don't have the images, but I mean, still 65 is abnormal. You don't expect this patient to be very anemic, I guess. And so I guess also that most of the indices were not in the good direction. So that's why you dealt with using...
High blood lactate, of course.
Of course, and I guess that vasoconstrictors also
it was just
probably...
for 24 hours. After 24 hours, the guy was okay, and so stopped the butamine and norepinephrine too, and she went okay.
I think that 65 is still abnormal. I mean, remember that ours VO2 is 75%. So, I mean, it's still 10% below. So we accept 70%, 65 is moderately abnormal, and so it's very difficult to know exactly what is the cause. I mean, it could be still persistent hypovolemia, can be indeed myocardial depression, and perhaps indeed your patient was with a normal cardiac function when you expect some hyperdynamic function, because indeed he's young, under vasopressors, you expect this patient to be hyperdynamic, and if it is just normodynamic or borderline with a 50% ejection fraction, is already quite impaired. So again, I think that we don't discuss too much on one specific case, but I mean, it just highlights the fact that measuring multiple variables and integrating these is very important. We don't make any decision based on just one measurement. In my mind, at some point, cardiac output will be measured, and if I continue on what you mentioned, Jean-Louis, I think that it's perhaps, given what you mentioned, a little bit too early to say that we will need cardiac output measurements, but it's also a little bit late at the same time. In my management, what I like to do is to, let's say, anticipate. I don't want to be reactive, I want to be proactive. And so depending on the severity of the patient that you anticipate by your first assessment, including the point of care echo, I think that helps us to guide already the management before. And when you decide to insert the arterial line, it can be already a dedicated arterial line that can help you to have the cardiac output measurements if you think that the patient will have a poor evolution. So I think that already up front, I like to have the discussion with the people in the emergency department when we discuss what type of support we will provide to the patient. And sometimes, indeed, we say, okay, we would like to have a transmural dilution in this patient, and we already insert the adequate catheter at that time, rather than inserting a radial artery and then 2 hours, 3 hours later, putting a femoral artery with the other one.
Xavier, can you summarize some of the statements proposed by the ESICM consensus about SCVO2, PC2 gap, etc.?
Yes, indeed. It's an update of the previous consensus conference of the European Society, and it should be published, I hope so, in the next weeks now in ICM. And the key is that we say we should assess the adequacy of cardiac output. We say that SVO2, SCVO2, PCO2 gap, and lactate are mandatory for this purpose. We suggest that the ratio of the PCO2 gap over the arteriovenous difference in oxygen content, which is another marker of anaerobic metabolism, may be used. And we say that all the indices should be interpreted together. All the decisions should not be taken on only one variable for assessing cardiac output and the adequacy with the oxygen demand.
Okay. Bernd, Daniel said if we have an arterial catheter in place, maybe it is worth it to measure cardiac output. Can we use every cardiac output monitor in this kind of patients compared to OR patients, for example? I mean, any pulse contour analysis cardiac output monitor, should we use only calibrated, or can we use uncalibrated? Can you comment about this?
Sure, of course. So I think we now agreed that at some point when this patient is not responding to our initial therapy, we have an indication for cardiac output monitoring. Another thing that we may discuss later, what our blood pressure target is in this patient with chronic arterial hypertension, but this is something we can do later. So we agree that we want to have cardiac output monitoring now because the patient is not responding to our initial therapeutic approaches. And in a patient with circulatory shock, I personally, and this is also what we recommend in the consensus, would go for a indicator dilution method. So this means either transpulmonary thermodilution, which is, as you know, a combination in a monitor with an intermittent indicator dilution method and a calibrated, externally calibrated, to be completely correct, an externally calibrated pulse wave analysis. Or in special indications, you can, of course, also use a pulmonary artery catheter, but in this patient, I would not use a completely uncalibrated or only internally calibrated pulse wave analysis device. Those devices that we very often use in the operating room, of course, have the advantage that they are relatively easy to set up. They can be connected to basically any radial artery. They provide cardiac output continuously. But the measurement performance, especially in patients and clinical situations where vasomotor tone is markedly altered or changes very rapidly, is not good enough to really guide therapy. So I would go for an indicator dilution method.
And what about non-invasive, for example, bioreactants or something like this?
Non-invasive cardiac output monitoring at the moment is not recommended in patients with circulatory shock. This is something that is reserved for the perioperative period, and also there, to be honest, it's mainly within research projects. So in patients with circulatory shock, I would not go for a completely non-invasive system.
Yes.
Regarding these non-invasive systems, don't you think that there may be an interest for the patient before the ICU? Typically, if this patient stays a long time in the emergency room, where monitoring with cardiac echo is very difficult, where of course it's not possible to use more advanced devices, if the patient stays for more than 1 liter of fluid loading in the emergency room, wouldn't there be a place for some non-invasive devices before the ICU admission, and then of course not?
Even in patients with shock, sepsis?
Better than nothing, I would say.
In theory, you are correct. I actually don't know centers who routinely do non-invasive cardiac output monitoring in emergency departments and then kind of escalate the therapy in the ICU. It's theoretically yes, but I think the patient benefits more if he or she is transferred to an ICU quickly. And depending on the country you work in, perhaps you also insert arterial catheters in the emergency department. So I agree with you in theory, but honestly, in my clinical practice, we do not use a non-invasive system before the patient is then admitted to the ICU and switch to an invasive one.
And what is the place?
Echoes, definitely.
If we
I
go
don't
back to
consider
the
echo
emergency,
monitoring.
because Xavier went back to the emergency situation and department, if we go back to this, can you comment about the use of perfusion index, the use of capillary fill time in this kind of patients without any catheters?
Well, I mean, it's a signal. So if you do a fluid resuscitation, and we studied septic shock, I think cardiogenic shock is something of a completely different, let's say, treatment trajectory. So if we keep to septic shock, if you do a full fluid resuscitation in the emergency room and capillary refill time normalizes, that's a very good sign. And you have a mortality of about 10%. If it doesn't, you have 50% mortality, and so you're still in deep trouble with your patient. But that's a signal. It doesn't tell you anything over.
Who does measure capillary fill time? Who not? Who does not want to respond?
The others.
And perfusion index, because I know that you have a lot of research experience about.
Well, that's a very interesting tool because it's continuous. It comes from your pulse oximeter, and so you don't have to go to the bedside and do the manual compression and do a counting or either a stopwatch. So it's much easier for continuous monitoring. And we show that if you induce abnormal perfusion by lower body negative pressure or stuff like that, then your capillary refill time responds. It gets longer, and so vasoconstriction. And then if you take away the lower body negative pressure, it immediately becomes normal again. If you have abnormal capillary refill time, you give a vasodilator like nitroglycerin, you immediately correct the capillary refill time. Nothing much happens to cardiac output in these patients, to be honest, but still you let's say, take care of a signal. In the study that Alexander Lima did, I think the baseline cardiac index was 3 point something. So that's not a low flow state. But that's let's say, a high flow state with still abnormal capillary refill time that you can correct. We have no clue what it does on outcome.
Can you tell us what is the method, the best method to measure capillary refill time, CRT?
Well, the ones that we validated in the Andromeda study is use a glass. And the reason we use the glass is if you press the finger, you don't see anything. And so you press the glass on the dorsal side of the finger until you see a white skin. And then you do 1, 2, 3, 4, or you use a stopwatch. You keep it for 5 seconds, you release, you start the stopwatch, and if the color is back to normal, then that's the capillary refill time. That's the most, let's say, unbiased method that we could think of.
Well, new and biased methods do the same for the compression, but at least measure more precisely the recovery time using iPhones and others to try to indeed see the very precise time of the CRT, and this is done by Aitofela in Paris and others here in Belgium also. And this helps to have the possibility to have your CRT measured with a precision of decimal, which is useful when you wish to have non-invasive tests of responsiveness of the capillary refill time, which is a little bit more complicated if you wish to do this just by the with the second without any precision there. So that's why some people have advocated that with the passive leg raising test and other things like this, you may have the precision to detect this because using this kind of test. Of course, it's a little bit more cumbersome, and this needs, even though everybody have an iPhone, it begins to be a little bit more cumbersome, and so it needs to be really standardized if you wish to use it for this kind of tests.
And you validate the use between different people. Yeah. So if a nurse does the test, or a doctor, or a resident, which is with the compression, of course, very open to a lot of bias.
Xavier?
Yes, but even when you measure it with your iPhone, you mean that you film the recoloration of the fingertip, and then you review, you measure the time till it comes back to the. Even in this way, the reproducibility is not that good. And also, you're right, the fact that it should be standardized is of major importance. And I think it's rarely done. If we ask in the room who really uses a 10-second compression with the glass slide, it's while it should be done in this way. The first reason was that it's been done in this way in Andromeda 1 shocks.
But it depends really what you want to show as a problem. If you want to have CRT as a triage, you don't probably need to have a very precise measurement. And if you want to have really a purpose for targeting therapies based on changes in CRT, then you need to have precise and standardized measurement of CRT.
Okay, so we go back to the ICU because the patient is in the ICU. Bernd, you said maybe it's time because the patient is not rapidly improving. You said it is time maybe to use some more advanced hemodynamic measuring technologies. So what do you propose?
At this stage, again, I would propose to you.
I didn't tell you, but the chest X-ray showed bilateral opacities.
Yeah. Well, that is what we are assuming. So we are, of course, I think we need to make sure that, of course, we do things in parallel in critically ill patients. So, of course, we try to kind of diagnose the type of shock and treat the shock all the time and find the causal treatment. But the main reason for me to monitor cardiac output in this patient then would be to understand the type of shock. So this is a diagnostic purpose, and to monitor the response to therapeutic interventions, because at that point of time we've probably given I don't know how many liters of fluids. We've titrated up the norepinephrine, and I would like to understand more about the cardiovascular physiology, not only to understand what the cause of the circulatory shock is, but I also want to monitor the response to the interventions.
So you mean that this kind of advanced technologies is not only to measure cardiac output, not only the value of cardiac output is important, but probably the response of cardiac output and maybe other variables you can obtain at the same time?
Yeah, absolutely. So transpulmonary thermodillusion, for example, allows you to measure extravascular lung water, which I personally find a very valuable marker because it's, first of all, it's linked to, or it's a prognostic, has a lot of good prognostic value. And the more important thing is it gives you kind of a safety measure for your fluid therapy. So if we assume that this patient may have pneumonia, for example, and we already gave a lot of fluids, but extravascular lung water, for example, is still quite low, then I would be more confident in giving more fluids than if extravascular lung water is already 14, 15, 16, or even higher. So this is something that can give me confidence to kind of continue fluid therapy. And of course, other hemodynamic monitoring methods, pulmonary artery catheter, also gives you markers of cardiac filling pressures, preload variables. But in this specific case, where I now assume that perhaps pneumonia may be the reason, this even more would guide me into the direction of using transpulmonary thermodillusion because of the additional measurements of extravascular lung water and pulmonary vascular permeability.
Xavier, also the new consensus gave some statements about the use of advanced hemodynamic monitoring technologies. Can you comment about?
Yes, indeed. We recommend to monitor cardiac output in patients who do not respond to initial therapy. Of course, there is no very straight and clear definition of what is initial therapy, but likely initial fluid loading, small doses of vasopressors, and that's a clear recommendation. And then, regarding the type of devices we may use, we suggest using either the PA catheter or transpulmonary thermodillusion, as augmented by Bernd, to monitor these patients, based on the fact that these are reliable ways to measure cardiac output in these patients, and they provide more information than some less invasive devices. Finally, in the rationale, in the discussion, we say that cardiac echo cannot be considered as a monitoring device because it's very hard to repeatedly perform echo before and after every hemodynamic intervention. So while we recognize echo is absolutely mandatory and valuable at the very initial phase, we suggest it's not possible to use echo for repeated hemodynamic monitoring.
Thank you. Yes, Abele?
Of course, I totally agree with you. And I want to say also the utility of volume status that is addressed by global end-diastolic volume, because in very, very sick patients we find edema, not only pulmonary edema, but also edema of everywhere, and low volume status with low global end-diastolic volume. And so we have to monitor, because on the one hand we don't need to give too much fluids to the patients, but on the other hand we want to have a volume status that is compatible for the organ functions and the cardiac output. And so I was to point out to this, the global end-diastolic volume, the utility of these
devices.
Yeah.
How many of you use the transpulmonary thermodilution system and the PA catheter regularly? I mean, PA catheter regularly. And how many of you use nothing? When I say nothing, means not think more than arterial pressure monitoring and echocardiography and central venous catheter. How many of you? So it means that everyone uses in this kind of difficult situation, I would say.
But I mean, there is a bias. I mean, the title of the session is when to measure cardiac output. If you ask the same question in the panel of antibiotics just before, the answer may be different.
Okay. Just to know. Of course. But yes.
They're also dealing with infections.
I have a question. Again, thinking about resources and time, because our unit is 30 beds, sick patients, and putting, thermal dilution on everyone and overtime. So the question that I wanted to ask, relevant to the panel, is if we take this patient, perhaps this patient is a bit extreme, but a septic patient that is moderately sick, would you think that doing a point-of-care echo together with the venous saturation from the central line, together with the PCO2 gap, you can do also the extraction ratio, looking at the lactate, would that, in your capillary refill time, we haven't implemented it because it's so difficult to standardize it. We wanted to, but we failed, I'm going to be honest. Do you think...
Where do you work?
In Israel, in an academic center, a university-affiliated hospital, 800 beds. It's a big hospital. So in which cases would you think that then putting the PICO, the thermal dilution, is mandatory? Because many of these patients, in theory, yeah, we should put a PICO on almost everyone just to give the best possible care. But if it's especially in Israel, it's a Friday afternoon and you have an anesthetist on call, so the implications are significant.
What's wrong with an anesthesiologist?
Everything will depend, of course, on what are the results of your first test. I mean, if your first test, which is the basic, the ultrasound, is demonstrating normal cardiac function and you have normal SVO2 and so on, maybe it could be considered to stay on this line and to just repeat from time to time the echo. But I guess that if you have 30 beds and you say that you are busy, it will be difficult to repeat the echo in the 30 beds. So you need to monitor, just for that reason, the other patients, because otherwise you will just focus on the patient who is getting sick at some point, almost dying, and responding to emergencies, rather than really trying to be proactive and anticipating these issues. So I think that the cardiac output measurements is mandatory for the abnormal values. For the normal values, we don't care about it. I mean, and when it will be 6 liters, 7 liters, unless you are really doing something to try to improve cardiac output, it will not change anything when there is some fluctuations there. So I guess that once your patient is abnormal, like the one that Jean-Louis just presented, with everything that is abnormal, then this condition is good to have indeed the monitoring there, because what you do now will be different in 1 hour and different in 2 hours, and so we need to repeatedly assess this patient.
It also depends on, I think, on the presence of ARDS in addition to shock, for example.
Yeah, and I think that is what we mean with responding to initial therapy, because if you say you have a moderately sick patient with circulatory shock ventilated in the ICU, this is kind of an contradiction in per se, because this patient is very, very sick. He's not moderately sick, but I would say if you have urosepsis, for example, which kind of resolves with initial antibiotic therapy and fluid therapy, then you don't need additional monitoring if this is kind of resolving in the first 4 to 8 hours or so. So although it's very vague, I still try to defend our responding to initial therapy, because perhaps this captures what you mean. So if after a couple of hours things go into the right direction and everything seems to be under control, you know the type of shock, you know the reason, you started causal therapy, then there may not be a good indication for advanced monitoring. But if you have multiple organ failure and still don't really know what's going on, I would say there is a good indication for advanced monitoring.
In the case of, it's not the case in my patient, but RV dysfunction, what do you prefer? Only to use echo and repeat echocardiographic examinations, or to use a PA catheter? Can you comment about this?
I think that's a good indication for a PA catheter, because it's the only way to measure the pulmonary vascular resistance. And so, if there is an indication for one indication for the PA catheter, it is right ventricular failure, despite the fact that very few people use it today. And I think that indeed, the PA catheter is the only way to measure the pulmonary vascular resistance. And so, if there is an indication for one indication for the PA catheter, it is right ventricular failure, despite the fact that very few people use it today. And I think that indeed, One of the problems with transpulmonary thermodilution is that it does not directly assess the right ventricular function. Then, of course, echo is absolutely mandatory in addition for an intermittent assessment, just to see the geometry of the right ventricle, to measure the RV size, and to look for other problems. But what will allow you to precisely follow the changes induced by therapy, typically prone positioning, PEEP changes, etc., is the pulmonary artery catheter. And typically in our units, that's the case is where we use the PA catheter.
Daniel?
Well, I totally agree. I mean, and again, that's why I like to anticipate and to do the echo first, to try to orient my my best choice for hemodynamic monitoring. Because what I don't like is to put, let's say, a Pico device or whatever, and then to have to ask myself, oh, then we have a severe right ventricular dysfunction. It would have been better to put the PA catheter, but okay, it's costly. Whatever. Do we do it? I think it's better to do it upfront when you diagnose the problem initially. I agree with you that sometimes your patient converts and is with normal or adequate or seems to be adequate right heart function to begin with, and with the poor evolution of the lungs and ventricular settings, later on develops a right heart dysfunction. And then it's always a balance between the risk of the putting a new catheter versus the possibility to still handle this with the usual monitoring that is already in place.
And if you use a PA catheter, how long do you keep it? Is it safe to keep it more than 3-4 days?
I think so. We use it for more than 1 week if needed.
And for the transpulmonary thermodilution, Bernd or Xavier? Or?
We use it as long as we need to use it.
Usually after 5 days, we look for arterial infections, but the rate of infections of the arterial catheters are usually very low, including when inserted in the femoral artery. So it's, in my view, it's less a problem than with the PA catheter.
Questions? We have 5 minutes left. Yeah.
Can you use the microphone? Do you change your practice if you're treating a patient with peripheral vascular disease, significant peripheral vascular disease with diabetes, with regards to cardiac output monitoring?
Yes, indeed, it may be a contraindication for the femoral catheter. With one of the devices we have for transpulmonary thermodilution, it's possible to use a brachial catheter or a radial catheter, not that easy to insert, and the radial is more for the operating room, because otherwise you must keep the elbow straight, which is not easy in the ICU. But indeed, bear in mind that both invasive are invasive. Sometimes people say that transpulmonary thermodilution is a less invasive device compared to the PA catheter. It's not the case. And we have a study running on the complications of the transpulmonary thermodilution devices. No, it's an invasive device because of the femoral insertion. At insertion, with vascular injury, arterial injury, and at removal because of bleeding. So yes, it is invasive, and yes, severe vascular disease is a contraindication. And also several attempts for insertion, because all the accidents always occur when several attempts have been done for inserting this arterial catheter.
Yeah, and I can only re-emphasize that the removal is also very critical, because sometimes you need the bed very quickly in the ICU, you need to transfer a patient very quickly, and perhaps coagulation is still bad because of sepsis or whatever, so it's really take your time in removing the catheter and apply enough pressure and stuff like this. So the most dramatic complications with bleeding with femoral arterial catheters I saw happened after catheter removal.
So, other questions? So, if I summarize briefly, we talk about a patient with shock, in the case septic shock. The first things to do is clinical examination, CRT, mottling score or mottling, evaluation. Lactate measurement for following the evolution, probably yes. Jan, you are the prince of the lactate. And
The king.
what
The
do you
king of the
recommend
lactate.
is to insert a central venous catheter, an arterial catheter. Is it mandatory in patient with shock?
Yeah.
Yeah. If you do this, you recommend to measure SCVO2 from the central venous catheter, to measure PaCO2 from the arterial catheter, PCO2, the central venous PCO2, and to look at the difference, PC2 gap, and to perform echocardiography as soon as possible. This is 5 things to do. If you give a treatment, if the patient responds to the treatment, this is enough, of course. If the patient does not, this is probably time to think about more advanced hemodynamic technologies, and especially in patients with associated ARDS, because we know that it is a little bit tricky to manage fluid, to handle fluid management. This is a good summary.
Yeah, I would add one thing.
Yeah.
Whenever in doubt, so you did your first thing, whatever your first thing is. Whenever in doubt, start monitoring. Because it's informative as well. There's an educational thing as well. Learn what I increase the PEEP, I decrease the PEEP, I give fluids, I turn the patient, and then suddenly the blood pressure that dropped a little bit doesn't recover. Having these advanced technologies to measure what's really happening is really, really insightful.
But again, anticipate. I mean, you mentioned proning the patient is a good thing to do for the lungs and for the many things, but is exactly where you are in trouble when you want to measure something else than just blood gas. Yep. Because indeed, your patient is prone, you cannot do easy echo. I mean, we do it, I mean, with even transesophageal, but it's really more complicated to do at that time. So it's good to anticipate and to have a monitor that can tell you that something is occurring when your patient is 2/3 of the time in prone. Is very important. And the patient may be prone for 10 days. So for 10 days, you have no insight of whatever, so it's good to have monitors.
Sure.
And you cannot perform echo in this patient. So people who say they monitor patients with echo monitor nothing in prone patients.
Okay, it's time to conclude. Thank you very much for your participation.